Good morning, everyone, and thanks again for joining us for today's symposium. My first talk this morning will be on the hereditary genetics of kidney cancer. So briefly, the outline here is to really talk about the types of kidney tumors that we believe are inheritable. There's actually quite a few of these syndromes. The most common one, which many of you may have heard of, is VHL, but there's actually several others. And try and just give an overview of what these syndromes entail and some of the management considerations for patients who are either suspected or known to have these syndromes. So talk about the epidemiology, a little bit of the pathophysiology, and I'll sort of mix in the molecular pathophysiology, especially for those that are pretty well characterized. So as you guys can see here, these are sort of the most common types of kidney cancer that we encounter in treatment. Clear cell is the predominant one and certainly the one that gets the most research and the most consideration because it just affects most patients. Other types are papillary, which are sort of technically broken down into two types. Some people say three. These are less common, as you can see here, and then chromophobe rounds out the top three of the types of malignant kidney tumors that we see. There, of course, is other ones. Some of these other ones are translocation, the XP11-2 tumors, the medullary and collecting duct. Those are, just far uncommon. Unfortunately, all of them tend to be very aggressive, and even more disappointing is what we know about them and how to treat them. This is sort of the big list. This in 2016 was updated. As you can see, there's many different types of kidney tumors. Again, don't have time to go into all of them. Most of them don't tend to have a huge clinical footprint, but it's certainly something to be aware of. So when you're talking about hereditary kidney tumors, again, VHL is sort of the poster child of hereditary kidney tumors, and those are associated with the clear cell types, as you can see here in the top left. The papillary ones, we believe the MET gene really plays a central role in that, although there's certainly a lot more we need to learn about those types of tumors and those type of people who have those syndromes. Chromophobe and these hybrid and oncocytomas, which are sort of on the spectrum, are commonly associated with the folliculin alteration, and talk a little bit more about that, which is seen in a Birdhog Debate syndrome. The papillary type 2s, which are characterized by a loss in fumarate hydrase, or FH, are also a well-known disease entity. Talks more about that, along with the SDHB, or the succinate dehydrogenase associated genetic syndromes, and tuberous sclerosis, or TSC1 or TSC2. So starting sort of with the most common, and again, sort of the one we talk about most because we see the most, is von HippelLinda. This is an autosomal dominant syndrome. And as you'll tell throughout my talk, that tends to be the case with most of these syndromes, and it's that they are inherited in a dominant fashion. They're most commonly associated with the clear cell histology, and patients who have VHL, their history is pretty classic when you really take the time to ask them, as long as they know a decent family history. Most patients actually present without having any formal diagnostic or diagnosis of knowing they are VHL positive. That could sort of be said for most of these hereditary ones, since depending on how the patient first presented and their resources, a lot of times patients don't get early referral to genetics to diagnose these syndromes formally. They present in a clinical fashion. It's estimated that up to 70% of patients with VHL alterations will develop renal cell cancer, and most of them usually presenting anywhere from 40 to 45, although there's certainly outliers in that. So the classic manifestations, again, kidney cancer, clear cell being one of them, but there's also some other ones. This is not just a syndrome that's specific to kidney cancer, although that tends to get a lot of consideration just because of how prevalent it is in this population. But hemangioblastomas, which are tumors of the cerebrum, are also relatively common. They can also develop pheochromocytomas, which is an important clinical consideration, along with paragangliomas, which can also have functional status. There's also a list here, as you can see, of some other tumors, including endolymphatic sac tumors and pancreatic serous cystadenomas and neuroendocrine tumors of the pancreas. Pancreatic cysts are also something you commonly see in this cohort. And these are sort of the clinical ways we define the diagnosis of VHL. These used to be employed much more commonly and still are today, especially for those who can't get formal genetic testing, but majority of patients will go on to get a genetic test to confirm their diagnosis. So when you're managing these patients, really you're treating them different than sporadic kidney cancer, and that's an important case, especially on the surgical side. We use sort of the 3 centimeter rule because out of the NIH, there's some good studies and they have the most history of studying this population, actually defined it and discovered it, that when these tumors are under 3 centimeters, the risk of them spreading outside the kidney is very low to essentially none. And because these patients are going to develop, almost all of them, multiple tumors over lifetime, that takes a hit on their overall kidney function. So you have to balance the risk of intervention with the risk of kidney loss and subsequent need for dialysis, which certainly has its own considerations. So we sort of use this 3 centimeter rule, and to be honest, it's actually employed in some other hereditary syndromes, although it's not nearly as well studied in those syndromes. And this is, again, sort of balancing the risk and benefit for patients. For patients who have a diagnosis of VHL or are suspected to, really you need to try and prioritize partial nephrectomy if at all possible. For these types of patients, we'll cut really close to the tumor because positive margins don't mean as much they do in this patient population as they do in somebody who has a sporadic tumor. Again, getting back to the fact that these patients are going to get multiple operations, and the more operations somebody gets, especially on the same kidney, things get more difficult and the higher risk of renal loss. So that really, needs to be at the top of the consideration. What we don't like to see, ideally, is if at all possible, is these patients have a tumor that, while it may be very complex, undergo a nephrectomy when a partial could have been attempted at least. And then now you're dealing with a patient with hereditary syndrome, usually a young patient who only has 1 kidney, and majority of the time they will develop a tumor on the other side if they didn't already have one when they presented. So the other consideration in addition to kidney cancer is the pheochromocytomas. Like I mentioned, the recommendations from the NCCN guidelines is that these patients should get abdominal MRI imaging at least once a year. We prefer MRI, obviously, because of the radiation risk, and these are younger patients, and you're talking about following them for their lifetime. They should also get some blood work done, mostly to check for metanephrines, but any other endocrine abnormalities or functional testing may be indicated depending on sort of what their baseline is, or if you suspect they have a pheochromocytoma or a paraganglioma, which can also occur in these patients just a little less often. It's important you check this in anyone suspected of having VHL before surgery, since certainly this can affect anesthesia. I think many people are aware of, the consequences of not knowing if somebody has an active pheochromocytoma and taking them to the operating room. For the other tumors, which, like I mentioned before, the recommendation is every 2 to 3 years. For MRI imaging, these need to include the brain, cervical, thoracic, and lumbar spine. Next, we'll talk about the hereditary paraganglioma and pheochromocytoma phenotype. These are also commonly referred to as the SDH mutants, and it stands for the succinate dehydrogenase enzyme, which is part of the Krebs cycle. You can actually have mutations in 4 different parts: the SDHA, B, C, D, and 5 different parts, the SDHAF2 subcomplex. These are less common. They are defined by, again, autosomal dominant fashion. These patients tend to have more of a predominance for developing, as the name would tell you, paragangliomas and pheochromocytomas, but they do have an increased risk of developing renal cell tumors. So the most common one that we see is the SDHB, and it's estimated, again, the literature is a little sparse in here, but it's growing as we're learning more about them, that about 5% of patients will develop RCC. We don't know the true prevalence, but in all of the SDH, it's estimated that of all of the RCC tumors, that SDH deficient tumors are characterized about 0.1 to 0.2, so obviously rare. The important thing is, if you're managing or suspecting these patients, it's pretty easy to define whether they have any of the SDH mutations, because they all lose SDHB when you stain them on an H&E. So you can find out pretty easily using just pathology if you're dealing with a situation with SDHB. And if you have a really top-notch pathologist, they'll pick up on this and actually alert you to it in the pathology report. So the report, as far as managing RCC tumors, there's some consideration that people have suspected these to be more aggressive tumors. Others have said, really it's typical clinical characteristics that drive management, meaning the size, location of the tumors, other comorbidities. So we don't have a good way. I think for the most part, these are not recommended to be observed. So unlike the VHL, the 3 centimeter rule does not really apply to these patients. Certainly there's exceptions. Like I mentioned, if a patient only has 1 kidney, you have to weigh the risks and benefits a little closer. Again, these patients are at lifelong risk of developing these tumors, especially if they've developed an RCC tumor personally before. So partial nephrectomy is sort of the key when at all possible. course, if you have a sense that these are larger tumors, and again, the cutoff of 4 centimeters has been suggested in literature, or if you have biopsy showing low grade, then partial nephrectomy is preferred. For everything else being high grade, larger tumors, unfortunately, these patients need a radical nephrectomy even with a young age. So the surveillance for them is, again, similar. MRI is the preferred modality every 18 months, usually including basically head to toe, because again, the risk of paragangliomas is pretty high for these patients. They can get them in the neck, they can get them in other regions outside the abdomen. So you need to look at everything. They also need routine blood work and to follow with an endocrinologist because of this risk. CT imaging is certainly adequate and needed a lot of times when you're talking about surgery or intervention. There is some additional sort of PET scans that have shown to be highly, well, I wouldn't say highly, but very effective as far as diagnosing these paragangliomas, including the DOPA scans. There is sometimes an issue with getting insurance to approve these, but they do have a role and a place for this. Again, usually these patients are treated in a multidisciplinary fashion, so you try and use these only when needed, but they certainly can help you pick up sometimes some spots that are not obvious, especially if you're dealing with functional paragangliomas, picking up spots that are not obvious on MRI or CT. Again, similar to the VHL, because especially in this patient population, really need to make sure they don't have any kind of functional adenomas, paragangliomas, or pheochromocytomas, and you do that with, a good endocrine or functional workup, testing for metanephrines. Hereditary leiomyomatosis and renal cell cancer, or HLRCC, is the next one we'll talk about. This is characterized by loss in FH, or fumarate hydrase. This can be stained for and again diagnosed on pathology. They do have sort of a typical characteristic, and again, if you have a well-versed pathologist, they can alert you to this as well. These patients again have usually a pretty strong family history that identifies them, even if they don't have a formal diagnosis. When you're talking about patients who had their uterus taken out for fibromas or fibroids, at an early age, or every female had uterine surgery, even if they don't know the exact reasons, right? These are the things that kind of alert to you. The cutaneous leiomyomas are a little less common, but certainly something you can see. These are important ones to identify early because these pretty well known to be very aggressive tumors when they develop. So these ones are almost never watched, and you want to intervene as soon as possible. The recommendation at this time is not to consider these patients for partial nephrectomy for the vast majority. Again, exceptions can arise depending on how many kidneys a patient has or doesn't have. But really, you want to treat these aggressively because they've been demonstrated to spread outside the kidney at a relatively small size. In some cases, when the tumors are only a couple centimeters, which is certainly not what we typically see in the sporadic setting. So these ones, again, need to be screened. And if you know if somebody has them, especially as a children, you start the screening early so you can intervene early. So even starting at age 8 to 10, again, mentioned that these are aggressive tumors by their nature and biology. And so nephrectomy is the recommended surgical approach as long as the tumor has not spread. Next, we'll talk about Birdhog Debate. So this is one that's characterized by an abnormality or alteration in the folliculin gene. It's, again, inherited in autosomal dominant fashion. These patients sort of have the characteristic skin or cutaneous manifestations, including the fibrofolliculomas. You can see here sort of these little dots under the eyes. They can have them other places around the head, the neck, behind the ears. A lot of, the classic sort of teaching is they develop some pulmonary complications or pulmonary cyst and actually have an increased risk. And about a quarter of them will have a history of pneumothorax. So that sort of can be a giveaway. The considerations for renal cell cancer in this patient population is that they're at more prone to develop benign tumors or more indolent tumors compared to the other syndromes we just talked about, being a higher predominance of oncocytic or oncocytomas, which are benign tumors. There is some case reports about them having mixed phenotypes with malignant tumors, namely chromophobe, but that's a little bit being debated, but certainly, it's been recognized, but the true occurrence of those mixed tumors is a little bit up for debate. Saying all that, they can still develop clear cell renal cell cancer. So biopsies are really important in driving management for these patients. Again, they typically present around the mid-40s, which is common for many of these syndromes, but they can actually present later in life too, unlike some of the other ones, which tend to almost always be, below the age of 50. These ones can present later in life. Again, it's the history that really gives it away. The prevalence of RCC is estimated about 6 to 35%, and they do have a risk of other tumors outside the kidney, including parotid oncocytomas or papules in colon cancer. Talk about tuberous sclerosis. So this is another one of the more common or classic kidney cancer syndromes that we talk about. It's manifested by an alteration in the tuberous sclerosis gene 1 or 2. Both of them are sort of defined as tuberous sclerosis. It's actually not a terribly uncommon finding, estimated about 6,000 to 10,000 births. Most of these patients are diagnosed when they're pediatric. It's believed that about 2/3 of these cases are diagnosed without any formal family history diagnosis. Again, could relate to the ability of family members to get tested or just not having the knowledge about the manifestations. The TSC1 patients tend to have less severe as far as the syndromes and the presentation than the TSC2s. Almost all of them have some kind of skin manifestation, and the classic one is these shade green patches, which you can see sort of down here. The angiofibromas, which you can see down at the bottom. A lot of them will tend to have some psychiatric or autism kind of features. That's a little less clear as to why they have that. They are at risk of developing these tuberous growths in the cerebellum, or what they call tubers, hence the name tuberous sclerosis. As far as that having an impact on their brain function, it's a little bit less clear, but that's something that usually sticks out in this patient population. For them, when you're talking about renal or kidney manifestations, really it starts with angiomyelipomas, which are benign tumors. And this is an important distinction because if you think somebody has this syndrome, AMLs are treated very differently than renal cell cancer. AMLs in this day and age are primarily treated with interventional radiologists performing embolization. And for those who can't or won't get it done, there is actually therapeutic options with everolimus. So there's non-surgical options to treat and manage these patients, especially if they have other risks precluding them to, renal failure or something like that. So it's really important to try and diagnose these. Some of them, as you can see here, can look like solid masses. And if they're lipid poor, which a lot of these tend to be, sometimes your radiologists, unless they're really good, but even the best sometimes can't make a definitive diagnosis. So there's no loss in getting a biopsy on these patients if there's any question. And I think, again, with a lot of these hereditary syndromes, a biopsy is something we didn't tend to do as much in the past, but I think is getting used more and more. And I think it's allowing us to better manage these hereditary patients than we did in the past. So again, the considerations I mentioned, AMLs are what you got to think of most common. Now, they do have a risk of kidney cancer. It's estimated about 2 to 3% of TSC patients will develop RCC. Most of the time, these are clear cell, and they get treated like a typical clear cell would be in the other manifestations. Surgery is the approach. Again, some people employ sort of that 3 centimeter rule here. It doesn't have a defined rule, but again, the consideration of patients, kidney status, if they already had interventions, renal function, those kind of things all come into play. BAP1 tumor predisposition syndrome is sort of the newest kid on the block, so to speak. We've known for quite some time that BAP1 is involved in clear cell renal cell carcinoma, clear cell renal cell cancer tumors as far as their genetic phenotypes, but as far as hereditary syndrome, this one's sort of over the last couple of decades been more clearly defined. Sort of the unique feature for these patients is uveal melanoma, which you can see a picture here in the top right. They are at risk of developing kidney tumors, along with some other tumors, including mesotheliomas and lung adenocarcinomas. Again, because it's sort of new and it is a pretty rare event, we don't have a ton of detail on how these patients do clinically when they develop kidney tumors. Most people think biologically, because of the BAP1 rule, we know in sporadic tumors that these patients will have an aggressive phenotype, but that really hasn't been proven thus far. I think more people would err on the caution of treating these patients more like your hereditary or your HLRCC patients than your VHL patients, but that still needs to be studied better. I think last year we'll talk about hereditary papillary renal cell cancer, and so this is HPRC, and this is characterized by a loss in typically the MET gene or an alteration, sorry, not a loss, an activating mutation or overexpression of the MET gene. I would say out of this one, we probably know the least about its genetics. There's some talk that there could be multiple genes involved. And for some patients who have all the clinical signs and symptoms of having this syndrome, and they don't have a gene that we've identified as being altered, really means we just don't understand it completely yet. So a lot of this is clinically based. These patients are pretty classic in the fact that they're usually younger patients, young 40s, late 30s. They're presenting with the papillary type 1. They usually present with multiple tumors, bilateral tumors. And again, they need to be managed, you know, in a risk-benefit kind of fashion, usually trying to intervene only above 3 centimeters for these patients, and partial nephrectomy if at all cost. This is the one syndrome where we don't know, at least, or think that there's actually any manifestations outside the kidney. The other thing that's pretty common with these patients is their kidneys just don't work as well at baseline. So even though they might not be littered with tumors, these kidneys don't work as well. And so these patients, when you throw on top the fact that they need multiple kidney surgeries over the lifetime, their kidneys don't work as well as at baseline, they're at a higher risk of renal failure. So getting a nephrologist involved very early for these patients is critical to try and maximizing. So I mentioned, you know, the age of onset here. They, in addition to the tumors, can have multiple and bilateral renal cysts. These are actually pretty common. And for these patients, when clinical management is, you know, ultrasound isn't good because of the papillary types of cells, and especially since these can be smaller tumors, ultrasound just isn't good. So MRI, again, is preferred here. So lastly, this is just sort of overview taken right from the guidelines. You can see here sort of the recommendations at this point for starting screening. Now, these are for patients who haven't developed renal tumors, right? If somebody develops a renal tumor, you're going to do it different. You're going to do surveillance. And a lot of that depends on their characteristics and the tumor pathology. Here is screening when they haven't yet developed anything in the kidneys specifically, but you're looking to try and catch something early, and how early depends sort of on the pathophysiology and the hereditary syndrome the patient may have. All right, that's it. Thank you very much, and take any questions.